So I'm going to speak on adverse reaction to metal debris and what is its pathogenesis and how you can manage these cases. So it's very important to love challenges in life and also keep on learning. So by definition, what is adverse reaction to metal debris? It is the periprosthetic response of the body to the wear particles generated. It can have a spectrum from a small asymptomatic cyst to a large soft tissue mass, something like a pseudotumor. It has a vicious cycle in which initially there is inflammation that leads to osteolysis, then it causes loosening, and that causes instability. And the cycle goes on like this. Little bit regarding the history of metal on metal. So we have been like a seesaw or a pendulum in this case. Initially, the metal on metal was introduced by Philip Wills in 1938 using stainless steel implants, but the quality of that it was not very good and it went out of vogue. Then it was overtaken by Chanley's low friction arthroplasty. Again, there was a resurgence of second generation in which cobalt chrome alloy was used. Initially, it was cemented, and then in the third generation, it was uncemented. We also have hip resurfacing, which came into vogue in 1997. So this is all about the history of metal on metal hip in brief. So what is the love about this? Why everybody wants to get a metal on metal? So the advantages of that is that in a hip resurfacing, you can preserve a lot of bone stock. There is less wear as compared to polyethylene. There is reduced chances of head and liner fractures. And you can get actually a larger head in this, which eventually decreases the dislocation rate. What are the prerequisites for an adverse reaction? So you should know that there should be generation of wear particle and there should be body's response to it. This can be divided into either extra-articular factors or intra-articular factors. In extra-articular factors, you have articular wear, taperosis, tribocorrosion, and in the intrinsic factor, you may have hypersensitivity reaction, innate immune response, or adaptive immune response. So a little bit about articular wear. It depends upon the property of the metal itself and how it has been treated. Few metals are very strong and few have very poor scratch resistance. So if the implant is having very poor scratch resistance, that will lead to more articular wear. Edge loading is a very important concept and you should know about it, that if you get the alignment wrong in these cases, there will be a focal transmission of force, which will accelerate the rate of wear. This is a diagram of OPS technology, which is used by Professor James Sullivan in his cases. Other surgical factors which are important are the inclination of the cup, whether the stem is in varus, is there any impingement between the implant and the soft tissue or within the implant itself, high body mass index of the patient, and if there is any defective locking mechanism in the liner itself or at the taper or any other modular junction. So what exactly is taperosis? So as we all know that if we get our combination wrong, the results can be quite devastating. So regarding the taper, it has a differential diameter at both the ends, and the angle of the taper depends upon the length of the taper. And that gets fits into the femoral head. So if there is a micro motion in between the taper and the femoral head, that may lead to loss of metal, as shown in this diagram, that you can see there is loss of metal at both the taper as well as at the neck. What is the mechanism of it? As I told you, that increased micro motion can be because of the mismatch of the taper and the femoral head. Other mechanism is fretting or a tribocorrosion. To explain this, it is the body fluid with the passivation layer of the metal. It forms a closed circuit from which the metal ions are released, and that causes hypersensitivity reaction and taperosis. Other factors responsible are that initially in the taper, we had a long and a large design, which gave us less range of motion. So we went for a short and a narrow one. But the problem with this is that it caused edge loading and there was poor interference fit. Another mechanism which will lead to taperosis is that if you have two different metals, like a ceramic or a cobalt chrome, that may lead to a galvanic corrosion and there will be release of particles. This concept is very important and I would like to take home this one with you, that if you have a large femoral head and the force of the body acting on it acts as a torque at the taper, And then there is more force at the taper, and that causes micromotion, and there is release of metal particles. So more torque at the taper, leading to more wear. Other cases with large femoral head is that it may cause increased volumetric wear, and that may lead to adverse reaction to metal debris. So now we have basic knowledge regarding adverse reactions. So how to clinically examine this? So it masquerades as infection, and it is very difficult to differentiate between the two. So the history part is very, very important. You need to ask about recent infection to the patient, any surgical procedure the patient may have undergone, any metal allergy to the patient. The chief complaints can be pain, swelling, stiffness, or instability. On further clinical examination, the patient may show antalgic gait, and if the abductors are also involved, it can show a Trendelenburg gait. This is one of our cases in which there was a localized swelling, and you can also get a swelling in the limb due to the pressure effect of pseudotumor. It may also impinge on the neurological structures. Other rare manifestations can be a skin lesion or cardiac or neurological manifestations. Now coming to the investigation part of it, blood metal ion levels are highly overrated. So these are not the sole indicators for revising in these cases, but the general upper limit is taken as 5 microgram per liter. In case of taperosis, you need to understand that the passivation layer has more of cobalt. So whenever in a patient you're suspecting taperosis, then the cobalt level will be more than the chromium level. That is one of the indicators and a guide that taperosis may be present. Regarding the inflammatory markers, you can have increased ESR or CRP, but these are elevated also in periprosthetic joint infections. On aspiration of the hip joint, you may have a black fluid like this, which may be diagnostic, but most of the time there is only a serous fluid. So it is very difficult to differentiate from a joint infection. Other tests which can help you is a leukocyte esterase, alpha defensine, or a PCR. But this topic will be dealt in detail by Dr. Vaibhav. Regarding X-rays, you can see on the X-ray the alignment of the components. What is the inclination of the cup, whether the stem is in varus or valgus. Are there any signs of loosening or osteolysis? In this case, there is some loosening around the acetabulum as well as around the femur. Is there any bone defect? And in the later stages, you may have a dislocation or a periprosthetic fracture. MRI is a very important investigation in this case, like the Mars sequence, which is metal artifact reduction sequence, which can show local signs of inflammation, like a hypersensitivity in these MRIs, or it can show a pseudotumor or a soft tissue like an abductor involvement or an anterior impingement. You have a Anderson classification, which may show the disease severity, but it is not that highly used. Intraoperatively, you may have metal stained local tissues. There may be synovial hypertrophy. There may be sterile fluid or a cystic cavity. There may be solid tissue mass or a necrotic material. Histology is very important. You have a pathognomic lesion known as the alveolar lesion, which is aseptic lymphocytic vasculitis, as shown by the arrow. And if it is there, then that is pathognomic of an adverse reaction to metal debris. So what are the questions at our hand after this? Do we need to revise all the cases? So the answer to that is that if you have a symptomatic patient with a high metal ion level, with a pseudotumor, soft tissue involvement, and all the radiological features, you need to surgically intervene. You may also have a subset of patients in which you have a low metal ion level, but the patient is clinically symptomatic. These are the cases of hypersensitive reactions, and in these cases also you need to change the metal. You can also have an asymptomatic patient with a low metal ion level below 2. In these cases, you can observe the patient for some time. So what are the surgical considerations which we keep in our mind while operating? So these can be divided into either implant-related factors. So you have a situation in this both acetabulum and femur is loose. Then in that case, you need to revise both of them. You can also have a situation in which acetabulum and femur is well fixed. Then you need to inspect the taper. And if you feel like there is taperosis or micromotion at the taper, you can use a titanium adapter, also known as a bioball, with a ceramic head. In few cases, if the taperosis is because of the larger femoral head causing more torque at the taper, In that case, you have option of a dual mobility cup and you should change to a dual mobility. But if the situation is something like this, the taper is completely gone, you need to revise the stem. Other important things which you should know is the managing bone defects as well as the implant removal, which will be dealt by the subsequent speakers. They are expert in this. Soft tissue related factors are also very important. You need to thoroughly debride it like a tumor surgeon, and you should know how to manage the instability. If you have avulsion of the abductors only, you can repair it. But if there is a ball trochanter, you need to go for muscle transfer and you should have knowledge about it. Other cases means other implants at hand should be a dual mobility, a large head, constrained liner, and even a proximal femoral replacement. Regarding the patient factors, hypersensitivity to metal is one of the causes, and in those cases, you have to change to a ceramic head. Regarding the chances of recurrence and the surgical outcome, this is a systematic review of 216 hips, in which the complication rate was fairly high at around 50%. And the causes of recurrence was dislocation, again, ARMD recurrence, and acetabular loosening. This is another very good paper in which there was 27 patients. And the main thing to notice here is that it was metal on poly. So in metal on poly, you can also have taperosis. That is very important. And in these cases, all the cases were revised by using a titanium adapter, and only one case of recurrence was there. The most important thing was that they intervened early. You cannot wait for a longer duration to get all the soft tissue damaged, and then it becomes a very difficult job to reconstruct everything. This is one of our cases with Dr. Remy, in which there was a 60-year-old male, bilateral hip done in 2005. There was history of fall, and then you can appreciate in the X-ray, there are ceramic liner fracture particles present. This was then revised to a ASR in 2008 on the right side, following which in 2010, patient again came with groin pain, visual disturbances, skin lesion, MRI suggestive of particulate disease, inflammatory markers raised, and metal ions also rocketing high. The basic cause here was that because of the ceramic liner particle, it caused a third body wear and it accelerated the wear process, and the patient came with such complaints. So what was done is that a debridement was done thoroughly, pseudotumor was present, which was removed, acetabular cup was revised using an explant, it was removed and with minimum bone loss, and a same size cup with a screw fixation was done. It was changed to a ceramic liner with a ceramic head. And as the taper was not badly damaged, the stem was well fixed, so no revision was done on the femoral side. The main thing to take out of this case is that you need to revise a ceramic with ceramic on ceramic or ceramic on poly only. You cannot go for a metal line because that will increase the third body wear. So to summarize, it is the interplay of wear generation and body's response. Taperosis is a newer concept, but it can occur in any articulation. Thorough examination is paramount. LVEL and MARS are important for diagnosis. So the take-home message should be, it masquerades as infection. Blood metal ions can be dubious. Early diagnosis and intervention is very important. Preferably, you have to change to ceramic on ceramic or ceramic on poly. And these are difficult cases. You need surgeon expertise in these cases. So thank you so much for your time and listening patiently.